Hi, and welcome to Rush Memorial Hospital's joint replacement class. I just wanted to take a minute to say thank you for choosing Rush Memorial Hospital. We are committed to the success of your surgery, and we want to make sure that we meet and exceed your expectations. So that being said, let's get right into it. So first thing that we're going to talk about is, let's just talk about what we're going to discuss, okay? We're going to talk about preparation, we're going to talk about pre-op, we're going to talk about the actual surgery, what's going to happen after surgery, we're going to talk about in your hospital stay, the things that you can expect with physical therapy, and then also discharge and even lifetime expectations. Joint replacement is a lifetime commitment, and we want you to be prepared for what that entails. So let's go back to preparation. First thing we want you to do is go to your home. We want you to walk around. We want you to look for any kind of fall hazards, any tripping hazards. You'll see right here there are some purses on the floor, some toys, some cords. Take all of those and get them up. This is a good time to clean up your house. When you see the purse, this is also a good time to put hooks right at the door. Make sure everything's up off the floor. You see a nice picture of my cat Opie here. This can actually be a big fall risk. If there's any way you can maybe even rehome your animals for a couple of weeks. I know that we're all really attached to our animals, but what we don't want is to fall and get a wound infection because the wound opens up. It's really important. The other thing that we're going to do is we want you to make room for your walker. So we're actually going to send you home with a packet. If you already have a walker, then great. If not, and you haven't gotten one yet, this is just a piece of paper that shows you about how long the walker is going to be. What we don't want you to do is get home and have to move a lot of furniture around. So this is a good opportunity to take this piece of paper and walk around and make sure that there's no furniture in the way. Make sure that you can move freely with your walker. You will be using the walker for the first 2 weeks. We'll talk about that a little bit more here in a minute. Stock up on groceries, meal prep. Of course, if you can get your family to help you with this, that'd be great. But go ahead and get some foods prepared. Make sure that you have all the groceries you need. We do want you to move around after surgery, but we want it to all be in a controlled situation, meaning we don't want you to go out to the store. We want you walking around your house that you've prepared, that you've gotten rid of any fall hazards. Keep your items close. Now, what that means is that when you go home, we want you to set up a space that's close to you, so that you can grab stuff without having to get up and down. Once again, it's just a controlled situation. So get a table, you'll put your unscented spirometer there, anything you need to drink, and then so that way when you get up, it is controlled, it's when you want to do it. Consider items like reachers and stuff like that to help you. And then if you have a first floor and you can prepare it, it's not necessary, but it's definitely something that you may want to think about. The next part of preparation is get in shape. Now this is very important. We're going to give you this book. It's going to have some post-operative exercises, but we want you to start those right now. Go ahead and start to walk, start to really engage yourself, get mobile, get loose. You'll be surprised how much that will help with your recovery. So the next thing that we want you to do is watch your diet, control your diabetes. If you come in and your blood sugar is really out of control or your A1C is really high, then we can cancel surgery. We don't want to do that. So make sure that you're eating well, controlling your diabetes. Also keep your BMI less than 40. If you come in and your BMI has kind of crept up and it's gotten over 40, the risk of surgery is just too great. And we don't want to put you at any increased risk by going into surgery when the risk of getting infection is doubled, okay? Now, engage in walking, we talked about that, keep active. Stop smoking. Now, this is also a necessary thing that you've got to do. 6 weeks before, 6 weeks after. We want you to quit smoking. There are a lot of good websites. If you want some other referrals for help with stopping smoking, just ask us. The other thing is be honest with your doctor about narcotic use. This is very important too. We're not concerned with reporting you to anybody, anything like that, but it's really important that we know how much you're taking, how often that you're taking it. This can also affect your recovery from surgery. So moving on with preparation, let's talk about preoperative preparation. So we're going to give you this joint book. If you've got it, then we want you to bring it with you to surgery. We're going to do cryoneurolysis. We usually try to do that a week or two before. Sometimes we do it the day of surgery, depending. We'll give you a medical wash. We'll talk about that here in a minute. There's some lab work we'll want to make sure that we've got done. We'll want to do MRSA swab, which is just an MRSA, meaning we're checking you for a specific type of staph that can put you at increased risk with your surgery. And then we want to discuss home meds that you're going to stop before surgery. So there are certain things like blood thinners, certain over-the-counter things like fish oil, vitamins, turmeric, certain diabetes medicines you'll hold the day of surgery, and non-steroidal anti-inflammatory. So if you're on meloxicam, diclofenac, any of those things, we will stop those at least 5 to 7 days before surgery. So preparation, let's keep on with this. Now we've got our little friend, Mr. Doggy here. This is important because you want to know how long you're going to stay in the hospital, right? If you have animals, you need to make sure that you arrange for care for them. Like we said, if it's possible, maybe have somebody at least take care of your animals for 2 weeks, but we understand that that's not always a possibility. So, how long will you be in the hospital? These are just general rules. This is not hard and fast, but typically up to 65 years old, you can be up to 2 nights. A lot of times you're just overnight. If you are 65 to 80, it's usually at least 2 nights. And then if you're over 80, you can probably expect to be in the hospital for 3 or more nights. But once again, this is not a hard and fast rule. It just depends on how well you do with surgery, how well you do with recovering, how well you do with physical therapy. We consider health and mobility when we're talking about this. So even if you are 65, if you have a lot of comorbidities and a lot of other medical issues, you may be in the hospital longer. So once again, just make sure that you arrange house and pet care. So let's move on to surgery. Let's talk about what you're going to do for your surgery. So the night before surgery, no alcohol at least 48 hours before surgery. You're going to hold your meds, and we will give you a list of those meds that you'll need to hold, and you would have needed to hold most of these at least 5 to 7 days before. Pack light, comfortable clothes, something that you can move around in. Just remember you'll have a big dressing on your knee, so something that if you want pants that they're loose and that you can pull over the incision and the dressings that you'll have. Pack comfortable shoes with closed toes and backs. That's pretty straightforward. You'll do your surgical wash. I'll show you that in just a minute. You will also do your surgical wipes. Do not eat after midnight. This is very important. Now that includes chewing gum, no candy. When the anesthesia calls you, they'll talk to you about what meds you can take the next day. But you will talk to your anesthesiologist specifically about that. Make sure you have an updated medication list. So what I would do is go down and you can type it out, you can write it, but of course when you come into the hospital we will ask you over and over, what are your meds, what are you taking, what are you not taking, and it's a lot easier just to have all that information right there available. Do that with any kind of dietary restrictions and medical problems you have too. Write it out, type it out, just have it ready. Bring your CPAP machine to the hospital. So if you're on CPAP at night, this is really important. You can bring it to the hospital, you can wear it at night. And then of course you want to bring your joint replacement book to the hospital with you too. So surgical wash, let's talk about that. So we are going to give you a loofah and a bottle of surgical wash. You can see the picture of it right here. And then of course we're going to give you these surgical wipes. What we want you to do is you're going to go home, you're going to get in the shower, you're going to wash your face, your hair, and your groin just like you normally would. The next thing that you're going to do is take your loofah, take your soap. You're going to get about a quarter size soap on the loofah, and then you're going to start from the neck down and wash. Now this is front and back, so you may have to have somebody help you. Scrub from the neck down, avoiding your groin. And this is, once again, head to toe. Let the soap sit for 2 minutes, and then rinse it off. Now, after you rinse the soap off, do not wash with any other soaps. You're good to go, and you can get out of the shower. You're going to use clean bed sheets, and then also use clean towels, okay? And then you're going to wipe with the surgical wipes after you do all of this. The day of surgery. This is really important. We want you to arrive on time. Now, the arrival time is going to be different from your surgery time. That means that if your surgery is at 8 o'clock in the morning, they will usually have you here by like 6:45. So make sure that you understand that and make sure that you get here on time. You will go into pre-op. This is on the 2nd floor of the hospital. There you will check in. They will start an IV. They will also have anesthesia come in and talk to you. You will be given more meds. You will be given another surgical wipe to wipe your leg with. They will talk about when you can eat. I know everybody's always really hungry by this point. You haven't eaten. So they'll talk to you about that. And the physician will let you know how long surgery is. Dr. Ginther will come in again. He'll answer any questions. So a good thing to do is actually write them down at home, because sometimes what happens is you get anxious about stuff and you forget a lot of your questions. So write them down at home, bring them in. You're also going to get a medication that's going to help with decreasing your bleeding, and you'll get an antibiotic. and then you're going to get some more stuff, like I said, meds, and this all goes back to this multimodal pain strategy that we're going to talk about in a minute. So let's talk some more about surgery. Pain control. Now, Dr. Ginther uses this multimodal pain strategy that we were talking about. So you can look on this list, and you can see all the things that we have on here. We use a pain scale. We use cryoneurolysis. We use a tourniquetless surgery. Of course, they have general anesthesia. If you get a hip replacement, they do a spinal injection and periarticular injections. That's the Exparel that you'll hear Dr. Ginther talking about. Non-steroidal anti-inflammatories, Tylenol, steroids, and gabapentin. So I know this is a big long list, but all this means is that we do a lot of different things to keep you out of pain. We understand that knee surgeries is one of the most painful surgeries that you can have, but our goal is to get you feeling where you can walk around and do your physical therapy and get you out of the hospital and get you home. So let's talk some more about surgery. So you go in, you have your surgery done. The next thing that's going to happen is you're going to come out and you're going to go to PACU. Here you will still be a little bit groggy from surgery. They'll monitor you really closely. You'll be on a pulse ox. They'll watch your pain. This pain control starts immediately. If you're having a lot of pain in PACU, they have a list of meds that they can give you to help control that pain. Common complication after surgery is going to be nausea and vomiting, so don't be afraid if you have that after surgery. We give you meds to help you control that. Sometimes it's worse for people and sometimes it's not so bad. And then recovery from anesthesia can depend from person to person. So we just want your family to understand that. We don't want them to get too worried if it takes somebody a little longer to recover than it does someone else. Underlying complications can also add to this. So if you're somebody that's got a lot of comorbidities or problems with your blood pressure, then it could affect how long it takes you to recover. So once you are recovered from surgery, after that you're going to go to the floor. At this point, you're going to be admitted. You should be awake. You should be up and feeling better. Your floor nurse will check in on you, and we will also continue your pain control. And you will still have a Foley catheter in at that point. That is the catheter that drains your bladder. You'll have that in overnight, and your physical therapy is going to start today. And we want you to understand that. This is very important because if you get up and you walk around, even if it's just dangling your leg, we want you to get up and walk, and that's usually what most people do, and they have a lot of success with that. But it really gets you going, gets you out of the hospital. Most of my patients, after they have gotten up and walked around with physical therapy on the first day, actually say their knee usually feels even better. So this is something that is a high expectation that we have for you, that we want you to get up and get moving that first day. Another thing that we worry about is lung congestion. I'm sure you probably have seen these before. If you've had surgery, this is called an incentive spirometer. What you do is you take it, and we want you to get to 2 liters on this, or 2,000, and you'll do this every hour while awake, typically, every hour or two, and you'll breathe in, and you'll try to get to that 2,000. All that does is keep you from getting pneumonia. It's really important just because you had surgery. One of the big complications from anesthesia and being intubated is pneumonia. So we want to make sure that we don't have any complications with that. So the day after surgery, what's going to happen then? You're doing well, you got up, you walked around with physical therapy, and now first thing that's going to happen that you'll be really happy about is the Foley will come out. Now sometimes there can be complications from that, infection, retention, things like that, but we monitor those very closely, and we will do whatever needs to be done if we see any of those things happening. Physical therapy will visit you twice today. Compliance is very important, so be aware of your pain. Now all that means is that if you know that physical therapy is going to come at 10 and we will help you with this, but it may be a good time to take your medicine at 9 o'clock if it's due. And then, of course, bowel health is always very important. You will be on Colace. Narcotics, when you're on those, can cause you to have constipation, and that can be a really bad complication. So we will automatically put you on Colace and get you up and moving. That will help with any constipation as well. Of course, you're going to be on pain control. Usually oral meds are sufficient, so you'll be on oral meds, you will be on a narcotic, you will be on a non-steroidal anti-inflammatory, and you will be on a Tylenol. And the NSAID and the Tylenol we will do around the clock, and the narcotic will be as needed. Now, let's talk about your knee a little bit. It's going to be hot, and it can have some redness, but this is normal. the temperature of the knee can get up to like 105 degrees after surgery. So if it's real hot and it's real stiff, don't worry. That doesn't mean that it's infected necessarily. That is just something that's a normal process. Like I said, stiffness is very normal, so just be aware of that. Sometimes people can wake up and it feels really stiff, but with the swelling and stuff, you have to consider that there was a lot of work done in there and the body reacts to that, so the knee gets swollen. So going home, let's talk about some of these discharge expectations. So if you are in and you're in overnight and you're able to go home the next day, typically what we do in the hospital is we like for you to get 2 physical therapy treatments. So once again, PT will see you twice, once in the morning and then once at night, in the evening, usually about 2 or 3. So if you're going to go home that day, you can usually get out of here by like 4 or 5, just depending. Of course, this is different for everybody, but what we want you to do is when you do go home, we want you to follow up with physical therapy, usually within 48 hours. We have a discharge manager that comes in and will help us make sure that we're set up for that. You can actually start to look at rehab yourself right now, call around to some places. And if you've been somewhere before, just have that information for us. It helps us expedite those things. And some people even call ahead and get their physical therapy set up beforehand. And if we need to change anything after you get into the hospital, that's fine. Home physical therapy versus outpatient PT, like I said, this will kind of go on an individual basis and depending on your insurance, so that can all be assessed within the hospital. Now, the amount of physical therapy is going to depend on the range of motion of your knee. So if you come in and you do well, you get your croneurolysis, you get your range of motion up to 90 degrees, then you may not need as much physical therapy. So just kind of be aware of that. If you only need physical therapy twice a week versus 3 times a week, it just is usually dependent on how well you're moving your knee. You will always use a walker. Do the exercises in your book, okay, and you will always use a walker until physical therapy or your physician clears you, and this is for the first 2 weeks. So what will happen is you'll start to feel better, you may get a little lax with your walker, but at that point we still don't want you to fall. Okay, for the first 2 weeks it's really important that we don't open up your incision. So, you know, even if you've got your walker right there carrying it around, make sure it's always with you. Physical therapy will come in while you're in the hospital and actually show you stuff like how to transfer, walking up steps, those kind of things. And we want you to move every hour. We will talk some more about complications, but getting up and moving every hour will help really minimize complications like constipation. We'll talk about blood clots in a minute. So it's important that you're not sitting around not being mobile. So continue on with going home. We're going to talk about pain control. Elevate your foot. Now, when we say elevate your foot, it means that it's got to be above your heart. So if you're sitting in a recliner and elevating it, it's still below your heart. So we need you to kind of get it up above your heart. You can use ice. We'll send you home with a cryo cuff. You can continue that at home. And then you will be taking Tylenol and non-steroidal. We'll take those around the clock for the first few days, especially if you're still on any kind of narcotic. What we want you to do is wean your narcotics off first, and then you will wean your non-steroidal and then the Tylenol. So that's the order we would like for you to go in. So surgical incision. So when you go home, you will have a dressing. It's usually called a honeycomb dressing. Sometimes they do Primapore, it just depends, but the honeycomb dressing has a lot of holes in it. But this dressing is a dressing that is waterproof, that you can take a shower. But of course you're not going to sit in a tub, no sitting in a pool, no sitting in a hot tub. It's just for a quick shower that you can use this. No antibiotic creams. Hand washing is very important. Make sure that you are following strict infection prevention type activities, meaning always wash your hand, don't touch your wound if your hands are dirty. If you have to change your dressing for some reason, make sure your hands are washed, don't touch the inside of the dressing, those kind of things. Observe for infection, which we'll talk about more here in a minute, and if you do, once again, if you do have to change your bandage, keep it clean. So let's talk about infection. Infection can be a little bit confusing, and sometimes you're not sure if it's infected or not, because the knee is hot and swollen when you get out of surgery at first anyway. So let's talk about the redness. How do you know when to worry about the redness? Well, number one, usually if it's infected, the redness goes from a lighter red and it goes to a darker red and starts to spread, as we can see over here on this second knee. You will often see more swelling as your pain goes down. Now on day 3, when the Exparel wears off, you often have an increase in your pain. But after that, if you've had a constant decrease in your pain and all of a sudden your pain goes back up, then it should make you kind of think about infection. And then if you see any kind of drainage that's green, yellow, any kind of it's got any kind of foul odor that smells bad, then call us right away. We would rather know about it and have it reported to us so we can manage it if we think that it is something that's infection. So more complications. Now, we're not trying to scare you. This doesn't happen often, but we want you to be aware of these things. So blood clots, deep vein thrombosis, or pulmonary embolus. Now, deep vein thrombosis is a clot that forms in your legs, and then if it breaks off and it goes to your lungs, that's called a pulmonary embolus. So we do a lot of things to prevent this. It's, like I said, it's pretty rare that this happens, but what we want you to do is understand the symptoms and know the symptoms so that if you have those, you go to the ER. Prevention includes anticoagulant. We send you home usually on aspirin for 6 weeks, so it's important that if we send you home on aspirin that you understand that that is for anticoagulation. You do that twice a day for 6 weeks, so you're not going to take that even if you don't have pain, because it's not for pain, it's for blood clot prevention. Mobility is important. You'll have TEDs at home, which is the hose that go up on your legs, and then we talked about continuing your aspirin for 6 weeks. So going home, let's talk about the symptoms of DVT. You can have pain or swelling in the limb. It can be sharp, sudden pain, or like a muscle cramp. The point of that is it can kind of be a lot of different manifestations. What I find usually is people have more like a crampy type muscle pain that I've seen in the emergency department. Tenderness and warmth to touch. The onset can be gradual, and it can be worse with movements such as walking. So in the hospital, what you'll see is they'll come in and they'll move your foot up and down, and they will do that with each of their assessments, and all they're checking for is to make sure that you don't have calf pain. That's called a Homan sign, and if it's a positive Homan sign, we would tell Dr. Ginther, and he can just evaluate to see if we need to worry about a blood clot. So the other thing that I've seen before with blood clots is a change in the skin color. Usually I've seen more of a reddish color, but I have seen blue before, and or the skin has gotten very pale. Of course, we talked about the Homan sign. So the next thing that we're going to talk about is pulmonary embolus and the signs of that. Now, this is very important. If you have signs of DVT, you can call Dr. Ginther, you can call your primary care. But if you have signs of a pulmonary embolus, we want you to go to the emergency department. It can be the closest emergency department to your house. So sudden onset of shortness of breath, any kind of sharp knife-like chest pain. It's worse when you take a deep breath oftentimes. If you're coughing up blood, if you have a sudden fear of doom, not sudden fear, if you have a sudden feeling of doom or of just a fear, that can be a big sign. If you collapse, if you have any profuse sweating, dizziness or wheezing, any of those signs, you would need to go to the emergency department. Once again, those things don't happen often, but we just want you to be aware of those things. So complications, sometimes you can get nerve damage. Now, when he does the surgery, when Dr. Ginther does the surgery, you do always have a little bit of numbness on the outside of your knee. That's normal, but sometimes you can get some more in other places. So just kind of be aware of that. PT will assess you for those things. Like I said, warmness is normal, but we also want to watch out for the signs of infection that we had showed you earlier. Loosening of the prosthesis can happen, but it's rare. But if something you're concerned about, just talk with Dr. Ginther about it. Of course, you can get wear, you can get breakage. Lung congestion is another big one. So we're actually going to send you home with this incentive spirometer, and we want you to continue it at home as long as you are not back to your normal activity level. Okay? Constipation, this is very important. If you get home and you haven't gone to the bathroom in 3 days, you haven't had a bowel movement, you haven't pooped in 3 days, we want you to call the office, okay? We don't want you to get so constipated that it causes other problems. So just call us. We can give you something stronger to help you go to the restroom. So follow-up appointments. You will follow up with your doctor at 2, 6, and 12 weeks. We will give you mobility goals, but we want you to keep them realistic. I had a lady the other day that walked a mile 5 days after surgery. Now, that's the only problem with the cryoneurolysis is that sometimes it gives you such good pain relief that you're not thinking rationally. That's something that you would want to take very slow. You don't want to overwork your knee and cause any kind of opening up of the wound, but we definitely want you moving around and getting around as much as possible, but just kind of keep those things in mind. Also keep in mind that those goals are not for everybody. If you're not meeting those goals in a timely fashion, don't get discouraged. Just keep working. So lifetime appointments usually every 3 years, and then what's going to happen is that if you ever need any kind of dental work, any cleaning, if you ever have to have any kind of abscess drained or anything like that, you need to let Dr. Ginther know, because we may need to give you antibiotics. What can happen is if you get your teeth cleaned, it really can stir up bacteria that can seed, so we want to make sure that all that is treated before that happens. You will be given an implant card to carry with you at all times. It'll just kind of let you know, so like if you needed to get an MRI, they'll know if that is MRI compatible, those kind of things. And then of course we'll talk about lifetime activities with you. There's really not a lot of restrictions, except there's going to be no high impact sports like running, you know, no kind of crazy jumping with CrossFit or anything like that. But for the most part, there are really not a lot of limitations to that. So thank you so much for watching this. I hope you feel more prepared. If you have any questions at all, you can always contact me, Summer LeSar. I've got my email and my phone number, and just let us know, and we are going to take excellent care of you.